So good afternoon, everybody. Thank you very much for coming. I think it's just the batting and the fielding team, and maybe very little cheerleaders or whatever. So today from Gynae 2, we are presenting an experience of congenital cardiac disease in pregnancy. So of all the medical disorders in pregnancy, I think heart disease is the trickiest. And when we get a woman with a pregnancy with a complicated heart disease, particularly a congenital cardiac disease varying from a simple to a complex, it is not just a test of our wits, but also the guts. But needless to say, we manage them very nicely, very smoothly, courtesy the collaboration that we get from our colleagues in cardiology, CTVS surgeons, the medicines, and of course, the anesthetists. So to share our experience of the last 10 years, we present the data. And to take you through the data, we have our senior resident, Dr. Akanksha, who will highlight the cases that we've seen. And reviewing the literature will be our faculty, Dr. Sonia. And of course, we'll be followed by our experts coming from Dr. Ramakrishnan, Dr. Devguru, and Dr. Rashmi. So over to you, Akanksha.
Thank you, ma'am. A very good afternoon to all the esteemed people present here. We, Unit 2, Department of Obs and Gynae, are going to present our clinical grand round. Our topic is congenital cardiac disease in pregnancy, our experience of 10 years. So, the outline for today's presentation, we would be discussing about the magnitude and spectrum of congenital heart disease, unique challenges posed in pregnancy. We would also discuss the maternal and perinatal outcomes in women presenting with congenital heart disease in pregnancy. So, prevalence of heart disease is around 1 to 4% in pregnancy. Overall, it comes under the indirect cause of maternal mortality. Overall, in the world, it is around 27% indirect cause of mortality, whereas in India, 9% are the indirect causes of maternal mortality. We are still hemorrhage is the main cause. Coming on to the spectrum of heart disease in pregnancy, including congenital heart diseases, valvular heart diseases, cardiomyopathies, ischemic heart disease, and rheumatic heart diseases. In the world, congenital heart disease amounts for around 57%, whereas in India, we still have RHD as the main contributor to heart disease in pregnancy. Whereas, but congenital heart disease contributes around 1/3, around 30 to 40%. These women born with congenital heart diseases have a lifelong challenge starting from birth. They require multiple repeated operations and interventions. And the major challenge comes when they become pregnant. Or there is already a burdened heart, which is overburdened with physiological changes in pregnancy. So they have adverse cardiovascular events, including heart failure, arrhythmia, thromboembolic events. They may also have obstetric complications like hypertension, preeclampsia, antepartum hemorrhage, and neonatal complications like prematurity, growth restriction, and fetal malformations in their baby. So here we are sharing our experience. So we retrospectively collected data for past 10 years of pregnant women with congenital heart diseases delivering at our institute and compared them with women without any cardiac diseases in a ratio of 1:1. Our aim was to describe the spectrum of CHD. We wanted to analyze the maternal cardiovascular and obstetrical and perinatal outcomes in women with CHD compared to control groups. We also compared the maternal and perinatal outcomes between women, CHD women having with acyanotic and cyanotic heart disease, and also compared women with or without any prior cardiac interventions. In our observations, we had total around 17,000 women delivering at our institute in the past 10 years. Of these, around 1.8%, that is 302 women had heart diseases. And of these 86 women, around 28.5% of the heart disease were from congenital heart diseases. The baseline profile of our women with CHD, around the women the mean age was around 26, and majority of them were primiparas. And around 18.6% women, they presented in modified WHO class 3 and 4. Coming on to the distribution of different CHDs in our study population, ASD was the most common congenital heart disease, contributing around 30%, followed by valvular heart disease around 21%, followed by TOF and VSDs. Based on cyanosis, around 30% of our study population had cyanotic congenital heart diseases, whereas around 55% women were operated for their CHDs. ASD was the most common acyanotic congenital heart disease, and around 17% of the ASD women were operated or had a cardiac intervention before becoming pregnant. Among cyanotic CHDs, TOF was the most common, and majority, around 55%, were not operated. Other cyanotic CHDs, majority of them were operated prior to pregnancy. Among the cardiovascular complications that we encountered in our CHD group, around 8% women presented to us in NYHA grade 3 and NYHA class 3 and 4. Around 7% women had pulmonary arterial hypertension. Around 6% women had heart failure, and around 9% women require ICU stay. Now, the obstetric outcomes when we compared the obstetric outcomes in women with CHD versus the controls, in terms of there was no significant difference observed in terms of gestational diabetes, antepartum hemorrhage, and preeclampsia in women with CHD compared to control. Whereas, coming on to the delivery, the women with CHD delivered at an earlier gestation. Around 17% of women required operative vaginal delivery. There was no difference between the cesarean delivery rate among the CHD and the control group, and the mean duration of stay was longer for women with CHD. Although there was no difference between the cesarean section rate among the two groups, but in women with CHD who underwent cesarean section, around 30% of the cesareans were done for cardiac indications, primarily cardiac indications, and these are the one among which severe AS was the main. Discussing the perinatal outcomes in these women, as we can see that women in the CHD group had babies of these mothers had more FGR, growth restriction, preterm birth, low birth weight, and babies require NICU admission when compared with the control population. As we can see that birth weight was also lower in the CHD population as compared to the controls. 2 women in this group had babies with congenital heart disease in the babies. Of these, one mother with coarctation of aorta had ASD in the baby, and one mother with the repair TOF had Epstein anomaly in the baby. We also did a subgroup analysis comparing the women with cyanotic and acyanotic CHDs. The cardiovascular complications when compared were higher in the cyanotic group, cyanotic CHD group, as compared to the acyanotic CHD group in terms of heart failure, pulmonary arterial hypertension, NYHA grade 3, NYHA class 3 and 4. When the obstetric outcomes were compared in the cyanotic and acyanotic group, there were slightly more antepartum hemorrhage and preeclampsia in women with cyanotic CHD. In the delivery outcomes, we have seen that these women required more. Women with cyanotic CHD required more hospital stay. Otherwise, the outcomes were comparable, except for gestational age at delivery, which was lower in cyanotic congenital heart diseases, significantly lower. When the perinatal outcomes was compared between the cyanotic and acyanotic group, the cyanotic group had significantly higher amount of higher fetal growth restriction, preterm births, and low birth weight babies requiring NICU admission when compared to the acyanotic CHD group. This is also reflected in the mean birth weight of cyanotic CHD women was significantly lower than the cyanotic heart disease group, and they also had a poor Apgar score. On comparing the acyanotic group with the control group, there was no significant difference except for low birth weight babies and NICU admissions in the acyanotic CHD group. The cardiovascular complications in the cyanotic CHD with and without intervention was done. In this, we have seen that there was women without intervention had higher NYHA presentation and more pulmonary arterial hypertension, and required longer ICU stay. There was no significant difference in the obstetric outcomes of these of women with or without intervention, except in the cesarean delivery rate, which was higher in the women without any intervention. In the perinatal outcomes, except for fetal growth restriction and preterm birth, which was higher in women without any intervention done for cyanotic congenital heart disease. We did another subgroup analysis based on the pre-pregnancy cardiac intervention, which were done in these women. Cardiovascular complications were higher in the unoperated group of CHD in terms of NYHA, heart failure, pulmonary arterial hypertension, and ICU stay. Although there were no significant difference between women operated as well as corrected or non-corrected for congenital heart disease, and no difference in perinatal outcome was also seen. So, as labor and delivery is an important and critical step in managing these patients, I would like to invite my anesthesia colleague for further discussion.
A very good afternoon. I'll be talking about the data that we have collected over the past 5 years from the Department of Anesthesiology, Pain Medicine and Critical Care. There will be slight variation because it's a 5-year data and the dates don't exactly coincide with the obstetric data. Coming to it. So having an overview, we've done 31 cesarean sections where we have provided obstetrical anesthesia care, and we placed 6 epidurals. Of these 31 cesarean sections, most of these, 17 of these have been done under subarachnoid block, followed by CSC in 10 cases. GA and epidural account for only a minor fraction of these. Having an overview of the types of lesions that we have had, as discussed earlier, the ASD has been the most common lesion, and the ASDs that we have seen have mostly been corrected previously. And now coming to what each of these specific lesions imply and how do they matter to the anesthetist, we'll be seeing in the following slides. So coming to the correction status, most of our patients have had uncorrected congenital heart disease, and only 16 of them have been corrected of the 31. The uncorrected uncorrected congenital heart disease account for a higher risk class in the WHO risk classification, and they do have a high risk of major adverse cardiac events, including ventricular failure. The corrected lesions are not totally innocuous. They may have residual RV dysfunction and pulmonary artery hypertension. Now, specific to the uncorrected lesions, there is always a risk of paradoxical air embolism, where we pay meticulous attention to de-airing IV tubing, and we avoid the loss of resistance to air technique while placing epidurals. We may use saline instead. The acyanotic heart disease form the majority of the lot, and they tolerate pregnancy much better. However, the acyanotic diseases with pulmonary artery pressures more than 40 millimeters of mercury do come under a high risk. The cyanotic heart disease, consequent to their hypoxemia, they may have polycythemia, which may predispose them to thrombosis and stroke. They have platelet dysfunction, coagulation factor deficiencies secondary to reduced hepatic blood flow, and they may have reduced ventricular compliance thanks to myocardial remodeling. So coming to the anesthetic plan, we do provide labor epidurals for whenever a vaginal delivery is opted. Cesarean is done under neuraxial and general anesthetic routes, where it may be done under the neuraxial. We provide lodospinal and continuous spinal epidural for the neuraxial mode of anesthesia. Now, the effects of uncontrolled labor pain are myriad, and they do have a higher. They adversely affect the cardiovascular systems by increasing the pulmonary vascular resistance and the systemic vascular resistance, and also on the respiratory system, thanks to the leftward shift of the oxygen dissociation curve, there may be decreased oxygen delivery. All of these are undesirable. So, placing a labor epidural prevents the worsening of the shunt, especially in the left to right shunt case where we do it, placing a labral epidural prevents the increase in the systemic vascular resistance. Typically, we place lumbar epidurals. CSE and dural puncture epidurals are also provided. We use low dose anesthetics, local anesthetics in low concentrations of 0.0625 to 0.125% bupivacaine and add fentanyl in 2 mics per ml doses. These are the typical doses. Doses may vary. In the right to left shunts, we avoid local anesthetics as they may uh, may cause a deleterious decrease in the SVR. However, neuraxial opioids are safe in these cases. As discussed earlier, subarachnoid block has been the most common technique. However, specific to each anesthetic technique, there are a few common points. Firstly, each of these things are tailored particular to each patient. We aim to maintain the optimal arterial saturation, and we take care to balance the pulmonary and the systemic flows. We optimize HV before preoperatively and take meticulous attention to abruptable prevention. Total of 17 of the 31 cesareans were done under spinal anesthesia, where a low-dose spinal was used. Typically, it's more preferred in more of the stable ACSG patients. We take care that we have an adequate blockade up to the T6 level. Typically, we use a low dose of 6 to 7.5 milligrams of bupivacaine and add fentanyl as an adjuvant and at 10 to 15 micrograms. We anticipate and treat post-spinal hypertension, which may affect our shunt dynamics. And it's treated by fluid co-loading and phenylephrine boluses. Total of the 10 out of the 31 cesareans were done under combined spinal epidural. The advantage is that there is a less incidence of post-spinal hypertension where an initial low dose of bupivacaine is supplemented with epidural top-up sequentially to reach the desired T6 level. Only a minor 3 out of the 31 patients were done under general anesthetic. General anesthesia does help us to provide a better control of hemodynamics. The central venous access and arterial line are considered a low threshold for all these high-risk patients. Induction is done typically by rapid sequence induction, where we administer fentanyl, lidocaine, or azmolol to suppress the intubation response, and a cardiostable hypnotic like etomidate is used. We maintain anesthesia with the volatile anesthetic and a nitrous oxide mixture, which is nitrous oxide is typically avoided if there is significant pulmonary hypertension. We avoid high PEEP if there is significant RV dysfunction. In a nutshell, in all these cases, we would prevent a very high increase in heart rate, maintain the systemic vascular and the pulmonary vascular resistance ratio, give an adequate preload, and always be on the lookout for arrhythmias. Follow up on Sonia.
Good afternoon, all. So, come to the discussion part here. First, when we see the global experience on the congenital heart diseases, the major data we had from the European Registry of Pregnancy, they provide their first data on congenital heart disease in 2019 to this 2021. They have total 5739 pregnancies in 53 countries and 138 centers, and they had 57% congenital heart disease out of them in an almost 11-year duration. So when we estimated it was 23 pregnancies per center, and we had 86 pregnancies with congenital heart disease in our center, and it makes a higher odds ratio of around 3.5. And in their results also, ASD was the most common defect among cyanotic, and the top was the most common among cyanotic congenital heart diseases. They also give data among the which defect completed pregnancies more, and it is the maximum completed pregnancies was more in ASD, followed by VSD, then pulmonary stenosis and aortic stenosis. When we look at our experience in the past, the first data on the cardiac disease was presented by Bhatla et al. It was a retrospective data of 6 years duration from 94 to 2000. They commented on cardiac disease outcome, and they have reported 11.4% of the congenital heart disease. Again, second data came in 2013. It was of 3 years duration from 2009 to 2012, and they reported 36% rate of congenital heart disease among total cardiovascular diseases. So when we compared it, it increased from 11.5% to almost 1/3. It is like 30 to 40%. When we also did an extensive literature review on the congenital heart disease in pregnancy, and we narrowed down our studies to 5. The maximum pregnancies was studied by Lammers et al. It was a retrospective study done in the Germany for almost 13 years duration, and they studied 7,000 around 7,000 pregnancies in women with CHD. The second data was presented as in ROPAC study, which was of the 3 to 9.5 women. Hardy et al. Presented a systemic review and meta-analysis for 12 years data, and they included 32 articles with 2,770 women. Then again, a publication of retrospective data from Canada in the JAMA network. They included around 2,000 women. And in our study, we had 86 pregnancies with the congenital heart disease. When we compared the cardiovascular outcome in these studies, we had a comparable heart failure rate of the European countries, as they had 6.6% and we had 6% heart failure rate. When comparing others, it is higher. We had a pulmonary hypertension patient of 7%. This might be the cause of this high incidence of heart failure rate. Our mortality is 1.1%, which is higher than their, although it was only one mortality in a case of cyanotic unrepaired patient, which was presented even NHA4, and it is totally unbooked patient, presented with the this complaint, not corrected, diagnosed at early in the childhood, but it makes our mortality rate higher than the other studies. We had 0 arrhythmia and thromboembolic events, and whereas heart failure rate is higher, paternal mortality and pulmonary hypertension rate is 7%. When we compare the obstetrical outcomes with the other, in our population, we are high risk for gestational diabetes and preeclampsia. So we reported higher rates compared to others in control as well as in the patient of congenital heart disease. As we already discussed, there is no difference in terms of obstetrical outcome between our control and the congenital heart disease group. Definitely, we had a higher cesarean section rate. It is again comparable to our control groups, but here we had 30% cesarean section due to cardiac disease, and postpartum complications were comparable to the worldwide data. Now come to the in terms of perinatal outcome, when we look at, we had higher rates of fetal growth restriction, preterm birth, low birth weight babies when compared to the other studies, like it was 10% in European data, it was 17% in Ramage et al. So it must, because it is again higher in our control population also. And we had 2 heart disease patients, 2.3% compared with the European data. Now come to when we again reviewed the literature on the congenital heart disease with and without prior cardiac intervention. There is Silva et al. Studied the data in the non-repaired congenital heart diseases, whereas Takastuki et al. Studied only in repaired congenital heart diseases. From AIIMS only, there is a data comparing the operated and non-operated heart disease, and in our pregnancy we also compared repaired with non-repaired defects. So what we observed, that we have a better outcome in the operated group. It was not statistically significant because of the less numbers, but it was definitely the cardiovascular outcome and perinatal outcome was better in the obstetric group, and it is comparable to all these studies. When we compare our only on the cyanotic group, we had only one study by Ladashore et al. They studied the effect of pregnancy on cyanotic congenital heart disease, and they found that it worsened the pregnancy worsened the condition in cyanotic heart disease. Our data is higher than their data. It is like they observed heart failure rate of 3%, and we had 15% rate of heart failure. Definitely, it may be due to the more unrepaired defect, more cyanotic heart disease in pregnancy, and they referred us in directly to refer to us. There is more and more data they directly refer to us without any correction. So all these shows the need of pre-pregnancy counseling and repair need correction before planning of pregnancy. So important highlights from our studies, we had 3 Eisenmenger cases out of 86, and all these had 100%, all these had heart failure, presented in NYHA4, all had admission to ICU, but we don't have any maternal mortality, stillbirth and neonatal mortality. But morbidity is worse. There are more all were low birth weight, all admitted to NICU, 2 were preterm, but there is no adverse event in terms of mortality, both maternal and fetal. When we come and we reviewed the literature in terms of Eisenmenger, they again showed a very high incidence of cesarean delivery, 95%, 50% heart failure, maternal mortality, 30%. Again, a study of Indonesia presented in 2021 showed the heart failure rate of 95%, 90% cesarean section rate, and maternal mortality of 40%. And perinatal outcome is also worse in their studies. We had 4 Epstein anomaly in our cases. This was 4 pregnancies in 3 women with Epstein anomaly. All presented us with the bad obstetric history. They had no issue when they presented to us. And definitely they have very good outcome in terms of mortality. No maternal mortality, no fetal mortality, no stillbirth was there. But in terms of morbidity, perinatal morbidity, all were preterm, low birth weight, had NICU stay. Again, there were case reports available on Epstein anomaly. Recently, ROPEC study in 2022 published their data from 81 Epstein anomaly, and they reported adverse event of very comparison to all. This is less adverse event, like 7% heart failure, 9% total cardiac events, no maternal death was there, but perinatal morbidity is higher, preterm birth again 25%. So it is comparable to our data only. So for further discussion, I would like to invite Ramakrishna sir from cardiology to give some expert comments. Thank you, sir.
Good evening, everyone. At the outset, I would like to thank the opportunity given to us. And it has always been a teamwork that I think for a few years now we are running an adult congenital heart disease clinic. Before that, it used to be a teamwork of individuals, one-on-one. Most of the patients were, especially the sicker ones who needed a better care. There was definitely a one-on-one communication with the consultant level. But now we are running an adult congenital heart disease clinic. I think the most important reason why our maternal mortality of Eisenmengers and all are low is because you are not presenting your abortion rates. Like we are able to, most of the times we are able to catch them and then send for abortion. So that is our critical step. Still, we are, I think in every year, I think we'll be aborting at least 2 or 3 patients a year who may not tolerate pregnancy well. So that is very important. That I think should be the focus that we should be working on. There are some, this is as good as it gets in a large institution. Ideally, we should be getting more. For example, we are operating roughly around 3,000 to 4,000 congenital heart disease every year at AIIMS. But obviously, the women are less. That is where the problem comes. Hardly there's a big gender disparity in congenital heart disease surgeries also. So automatically it translates into this many number of women. And most of the times, what happens in the periphery also, people are very comfortable if somebody had an ASD surgery, otherwise doing well, the patient may not be referred to AIIMS for delivery. So most of the time, there is a filter there also. So we often don't get a simple VSD operated who's followed up for delivery here. Most often than not, we get a patient who have some residual lesions. There's a residual VSD or a PH is there. So that comes to the important point, like we may analyze it like operated, unoperated. These are all very big spectrum. Each disease is different. Each surgery is different. When the surgery was done is very different. And some surgeries are palliative, some surgeries are curative. And some of the surgeries, even despite curative, will end up having a problem left over. And some of these problems are well tolerated in pregnancy and some of these problems are not well tolerated in pregnancy. So that is where the problem will be, that we may not be able to dissect out, even ROPAC couldn't dissect out because the numbers are too small. Like. So for them also, for example, if you look at tetralogy corrected, so one tetralogy will have no annuloplasty and the patient will be doing fine. The cyanosis is cured, RE function is fine, there is no PR. But the other patient, our extreme could be patient with severe PR, with severe RV dysfunction. That patients, how they are going to tolerate pregnancy is anybody's guess. I don't think much data is there. So that is where the problems come. But ideally, what we should be going forward is, I think we should be establishing a cardio-obstetric clinic. So that is where the real focus should be of such an interaction, that we should be establishing cardio-obstetric clinic. I think there is some interactive projects that proposals have been sent to ICMR. If that project comes through, also through that project also we may initiate that and keep it going. Because not only congenital heart disease, we get a lot of, primarily the post-valve replacement is a big issue. So I think the problem is that overall the numbers are going to cross over. Maybe by the time we finish, I think the congenital heart disease is going to be the number one cardiac disease complicating pregnancy, because rheumatic heart disease is coming down in incidence. So before I conclude, I just wanted to know what is this control group at AIIMS which had 57% cesarean rate?
Thank you, sir. Thank you so much. Now I would like to invite Devguru sir for their expert comments.
Good evening. Excellent presentation on a very tough, especially when you see some of them, many of them were in NYHA class 3 and 4. The remarkable things are patients with high PA pressures. The outcomes are exceedingly good, especially AIIMS, you didn't have any mortality. There are some patients who will have some high risk when they present with higher NY functional class 3 and class 4, or when they have a left-sided obstruction, severe MS, severe AS. Apart from this, the main thing which really affects the outcome is the PA pressures. As Dr. Rama was telling, post-op total correction, some of them will have no PR at all. Then the RV function is fine. Some VSD closure post-op, the PA pressures will go down when they are corrected at the early age. But they'll continue to have PA pressures if they are corrected late, or sometimes they don't reverse back. So these are some places where, more importantly, I wanted to know what is your protocol for endocarditis, infective endocarditis prophylaxis. Do you give, or how do you categorize? Not for vaginal. In cesarean section, you give. We get more often mechanical. The problem is mechanical valve. What we deal day in and day out is mechanical valve, because they are on anticoagulants. So that is the high. We have a cutoff. Warfarin beyond 5 milligram, there's high risk. We do suggest to the relatives and the patients to avoid pregnancy. There are some contraindications, especially AIIMS, if they had been picked up early, ideal would have been have termination pregnancy. Even termination pregnancy in AIIMS carries some risk. I will congratulate again, wonderful teamwork, anesthesia and the OG team. Thank you.
Thank you, sir. And before we open the house for discussion, just a few concluding comments from our side. In the data, I would say that what we always feel is that, the congenital heart disease is like the lesser cousin of the rheumatic heart disease. For our residents also, we find that it is less scary. But in the data, we found, some of the salient features that we found was the ASD is the most common CHD. TOF is the most common cyanotic CHD. And most ASDs were operated by the time the reproductive life began. So more of the ASDs were operated rather than non-operated. The important thing was that the perinatal outcomes were worse in CHDs in terms of FGR, preterm birth, low birth weight compared to controls. And that is probably, and then when we did the subgroup analysis, it was contributed more by the cyanotic part of the CHDs. And when we did that part, so we thought that when we looked into it into detail and we compared the acyanotic with the controls, the difference was not that much. So it is it's actually the cyanotic CHD which is contributing more to the perinatal adverse outcomes, and we can understand that it is the hypoxia which is leading to the adverse outcomes in those particular group. And interestingly, no difference was observed between operated and non-operated. And I think sir would like to probably comment on why we did not find a difference between the operated and non-operated group. Probably because the non-operated group would not have required surgery. Maybe they did not extend to that extent. So I think that is something that was another thing. Worse outcomes in the cyanotic group. Acyanotic group had comparable outcomes to controls.
significant proportion needed operative delivery for the cardiac condition, that is forceps, because we do apply prophylactic forceps in that particular period. The challenges, of course, were the cardiovascular complications and multidisciplinary team management, and planning the reproductive life is a key. So for our department, whenever a lady comes to us with CHD or any heart disease, we do a WHO scoring to decide upon the continuation versus termination. And I think we do take a multidisciplinary opinion from the cardiologist. So we do have a lot of back and forth on what is the need for termination? Is there a need for termination? What is the background of the patient? And before we actually go on, and whether she is within that time frame, whether she can terminate that pregnancy. And of course, with routine antenatal care and a strict feto-maternal surveillance, fetal echo becomes an important integral part of the women who do have a CHD, because we know that it predisposes to congenital heart disease in the fetuses. So planning of delivery and labor management, again, is a multidisciplinary team management where we involve the cardiologist at all points, and we do a pre-anesthetic checkup with the anesthesia team. And postpartum care and contraceptive advice becomes very, very important. So contraceptive counseling is extremely important, and awareness and education, and need for optimizing before the planning of pregnancy, and prior cardiac intervention wherever is needed, and need for regular follow-up. And I think for the first 2, 3, 4 points, we need the cooperation from our cardiology colleagues. And like sir said, urgent need for a dedicated cardio-obstetric unit, and that is a felt need that we have we are trying to put it up across. And I think that's, like sir said, is going to come sometime soon. So I think these are some of the points that we would like to put forward. And now I would like to request for comments.
TGR doesn't present or reflect the entire department. That's one thing. So if we were to put our data, it would be much more. And in the previous data that Dr. Neerja presented, and now I think we've seen a rise, as both the cardiology colleagues says, we're going to see them much more. So if you were to put, and if you looked at 158 centers from the ROPAC, I know Europe is small countries, but if you were to do a registry, I think we would outnumber most of them by the sheer game of our strength of numbers. So I think I'm happy to share that Dr. JB is here with me as the head of the unit. He's agreed that we can pool our data and probably publish our data, if we can't say as a registry, as a tertiary referral unit, which would be something. And with Dr. Narang right here, I'm sure we don't have to wait for an ICMR trial to come to start an obstetric cardio unit. I think we can start it right. We can sort of start it. We don't need, there's a willingness, and that's what I think most of our colleagues would agree. So with that, I think we're there, and we'd be happy to take any questions. Yeah, Rashmi, your question was very rightly acted. How do we answer cesarean sections? Well, we don't take pride in saying that we have an exclusive, referral unit, which is high risks. So we are bound to see, we are not matching apples and all. We're truly matching, because we're not looking at an obstetric population, which is a low risk. So in the realms of real matching, it's not actually matched. So our data is definitely skewed. Yes, it's not actually, because we just get by virtue of the numbers. We are a tertiary referral unit, which takes high-risk pregnancy only, and therefore we are bound to have higher cesarean section rates. So if we're really to reflect it, we would have to really look in, exclude all our high risk, and certainly the cesarean section rates would be lower. So I hope that answers the question. Dr. Sharma and anybody, I would want JB to give us comments.
If the mother is having a heart failure, that is save the life of the for voluntary coming to us and she wants to terminate. But if the patient is in failure, heart failure,
Sir. I think it's an excellent presentation, excellent experience, a vast experience you have got. Yeah, you got vast experience on this in this area. I would only like to make a few comments, like as Dr. Rama also said, that these are individual conditions. Like they all need to be seen separately, like ASD, VSD, tetralogy of Fallot, and also the aortic valve disease, AS, and coarctation of aorta, as you saw in some of the Western papers, they were there. So I didn't see coarctation represented in your data. So that is also one which you have to look at that. And one important factor in the pregnancy on how these patients behave is the systemic vascular resistance, which falls during pregnancy, and that is going to actually reduce the left-right shunt. Like in ASD and VSD, they are going to left-right shunt will reduce, but right-left shunt is going to increase. So that is the major factor, and that is what we see. The cyanotic patients, they do worse basically. And also, because pregnancy is post prothrombotic state, and in right to left shunt there is a shunting of blood to the left side. And so in the Western studies, we saw some patient had thromboembolic episodes. I don't know, in your experience, did you find any thromboembolic episode or stroke or something? So that would be interesting to see. Then, of course, the pulmonary artery hypertension is a very important factor. The presence of pulmonary artery hypertension really leads to increased risk in these. And, in our cardiac clinic, as you said, they often ask us, whether they should get married and whether, they should have pregnancy. So these are the issues that they are already discussed. But a joint clinic, I think, is the really way forward, and there is no problem. We should be able to work it out. And as compared, we saw that RHD, as compared to earlier study, and now the RHD proportion has come up, CHD has increased. That is because most likely RHD proportion has come down a little bit because of the various factors, and that is why the CHD proportion, seems to be rising. So I think once again, I would like to congratulate on this excellent presentation and experience. Thank you.
Yeah, thank you. Well said, sir. It has been a joint effort, as Dr. Nina has also said. So, but what Dr. Narang said, these are the basically any condition where there is raised pulmonary hypertension, whether primary or secondary. So they are the extremely high risk factors. So that's why Eisenmenger comes at top of them, or secondary hypertension, primary pulmonary hypertension, single ventricle, then coarctation of aorta, and uncorrected TOF, etc. With corrected TOF, the outcome is excellent, almost equivalent to the normal population. So what is nobody has mentioned about it, that periconceptual counseling is very, very crucial for these patients. And someone was asking about MTP. Actually, MTP in a cardiac patient is equally dangerous. And especially by the time they reach us, they are already 14 to 16 weeks of pregnancy. So second trimester MTP is almost equally dangerous as continuation of pregnancy. And there are also like if I do an MTP at 18 weeks of gestation, and there is a risk of metal mortality in that case. So I have intervened in that case. So blame will fall on me. But if we continue the pregnancy, then it's a natural process. So it may be better to let the pregnancy continue, then the natural outcome will be there, they do better. So MTP, especially in second trimester, is very, very dangerous. So ideally, periconceptual counseling. So please, whenever we have the opportunity, we know any of our relative having congenital heart disease. So it's sad that all pregnancies where the pregnancy have to be only accidental pregnancies or unplanned pregnancy. So this is more crucial for these patients. And then everyone we are saying, this single ventricle or primary hypertension, Eisenmenger syndrome. We said, absolute contraindication. Patient comes, either she shouldn't conceive or she goes for MTP. But has anyone asked about her opinion? Urge to procreate is so strong. That male spider knows that he's going to be eaten and dead after this, still he goes ahead. So same way, these women also know. So these women, we had patient, I still recall the lady admitted in AV3 ward. She was MCOM, beautiful girl. You feel like marrying your son to her, sir. So in fact, if any very beautiful thin patient comes to you, ladies come to you, so beware, they may be heart disease patient, because normally they can't be that thin. So she knew everything. She was offered not to conceive, still she conceived. And then she was offered MTP. She was intelligent, still she continued with pregnancy. Ultimately, cesarean section was done. I think Rasmi only gave an answer to her. She was alive. But on third or fourth day, then she died. But on death, she get a female baby, was there. And still there was a smile on her face when she died. So after delivery also these patients can die. In fact, more deaths happen in purpurium phase. I've seen many patients and they're talking to you, suddenly they are fine and suddenly they are gone. And still there was, like as if when she was dying, there was still a lot of peace on her face that I have left some, my genes in the world. And later on, husband left that baby to the, this, what do you call them? Anath ashram, and married again. So for someone, she put her life at risk. So please, we have a lot of social issues are also important for these patients. So, but we need to ask what does she want and that's important. But luckily, our sir AIIMS used to be 50 to 75% mortality, but I think last couple of years it is less, 25% or so. So thanks to you, and now I think most of the time we are doing cesarean section on them, and you are giving general anesthesia to them before we were trying to do normal delivery. And so as far as cesarean section is concerned, as a general principle, heart disease for post-graduate is a contraindication rather than an indication of cesarean section. Cesarean section to be done for strict obstetric indications or very few heart diseases like coarctation, as sir was saying, or very very few heart diseases in which especially aortic stenosis and coarctation. These are the two absolute indications. So thank you.
So I would like to know what is the reason for the increased length of hospital stay in the cyanotic heart disease patients? The length of stay was significantly more in these patients. Was it because of maternal indications or the neonatal indications? Okay, right. So just wanted to know whether the complications, the maternal complications are more in these group of patients or only because they're staying in the hospital because the baby is in the NICU?
Ma'am, in which population?
In the cyanotic heart
Cyanotic
disease.
group. Ma'am, majority the fetal complications were more low birth weight.
They were in the hospital for the neonate.
Yes, ma'am.
Right,
Majority of time, the postpartum stay is more.
Okay. And Emmanuel, I wanted to know what was the indication of general anesthesia in those patients, in the 3 patients that you mentioned? The indications. Sorry? So it's not mentioned there. Oh, and were there any complications in all of these patients?
None.
Intra and post-op?
Intra and
Nothing.
post-op.
Nothing.
None were mentioned. None that were mentioned.
Okay, it would be interesting to know that, if you can go through the files and find out some of these, the cases, whether they had any intra-op or post-op complications, and what were the indications for ICU transfer, and what was the outcome for those patients. That would be something that I think.
We can dig up on the data.
Absolutely.
Any questions from anyone?
I want to make a comment. So since anesthetists are here, oftentimes every woman comes back to me asking what should be the mode of delivery. And invariably we write the same sentence. It's actually I can make a stamp and put it in this card saying that it's only for obstetric indication. But oftentimes I find that they all end up getting a cesarean. So is it considered safer? But across the world it's a trend. Across the world it's a trend. But even though textbook write that it's all should be only for obstetric indication. So why is it happening like?
In most of this is what I felt when you go abroad and you ask your colleagues. I think the labor is unpredictable. You don't know in the middle of the night. Not that there's a distress to the patient and the relatives, there's a distress to clinicians. So that is one reason when you talk to your colleagues across the globe also, where their labor rooms have got absolutely an SDU and ICU, which is a walk-in. We are deprived of that we have to confess, but then that doesn't give us reason. But most of the times, I think that's the reason why we feel it's a joint responsibility, it's a shared decision, and we'll have everybody at the same time. Those are some of the reasons which sort of tilt us to take cesareans earlier than, as JB said rightly, that you should only be. So I think in theory that's right. In our practical understanding, that's why when there's so many, associated fetal indications, and we know the babies we don't want an outcome which is going to be compromised. Sometime we know there's going to be a hypoxic baby coming in, all those things. But I think we have a team which is working with us. I don't know whether Rivimi would agree, but whenever we talked with Dr. Rajeshri, that would be a lot of reasons where she would sort of send a referral. She would say, why don't we do a cesarean? Because we all are available at the same time. Any comments from you people?
I don't think the anesthetists have a say in that. So yes. So we would like to do these. If the patient is planned for a cesarean, we would like to do it in the daytime and not in the night, in the middle of the night. Obviously, the conditions are not optimum. The facilities are not there. So it's obviously, if it's a planned cesarean, then obviously we would like to do it in the daytime. But otherwise, if the patient is tolerating labor well and is, the hemodynamics are stable, we don't generally, ask them to terminate the pregnancy unless the patient is in frank failure, then obviously that is an indication, and the earlier we do it, the better.
Also because the FGR that we get with them are far more. So I think that is another reason for us to be inclined more in terms of comparing registries from Europe and others.
And especially cyanotic heart disease, you have a reason for the fetal growth retardation. So these patients obviously end up getting a cesarean done because of fetal indication.
Comparable with the worldwide. More predictable. We are able to control.
Yeah, correct.
Between theory and practical, we are
Yeah.
giving you our
Yes.
Many of them deliver normally, like especially RST patient, I mean, you leave aside congenital. In the RST, mostly we tend to deliver them normally only.
And especially now that we have labor analgesia, so it helps them undergo a normal delivery without pain, especially in valvular heart diseases. Yeah.
heart diseases deliver very fast. And some by
Mm,
nature,
yeah,
as
yeah.
Yeah.
babies
In
are
fact, they
small.
tend to a smaller baby. Delivery is fairly fast, and usually, like when I was SR, we would routinely put the minutes he was fully dilated. I mean, we would be ready with forceps. We used to do apply forceps, but now the latest trend is that we don't apply forceps because forceps also causes trauma. Like sometimes complete perineal tear. So that also we avoid. So what now a tendency to increase delay second stage is cut short by forceps, but routinely they deliver very fast because babies tend to be smaller actually. So then you don't have to apply, or ventouse can also be applied, that causes less trauma to them. So a prolonged second stage is to be curtailed, but routine prophylactic forceps are no longer applied now. And stress of labor also, sir, yeah. I mean, initially Eisenmenger.
Yes, in pulmonary hypertension, we prefer to give a regional more than a general anesthetic. Unless the patient is crashing, then obviously then we don't have a choice. But if as far as possible, we do a regional anesthetic, CSC or spinal.
Actually, no anesthesia is safer for them, no? To be honest, no? I mean, because they are very, very high risk. But yeah. But I mean, the trend initially we used to deliver them vaginally, but in this Eisenmenger syndrome, a trend recently has gone towards cesarean section more in them, and our outcome has definitely improved. So we used to have 75% mortality, 50 to 75. Now it is much less, 25%. In fact, we've had 8 cases in which all 8 survived. In fact, one I did a cesarean and baby patient survived, her baby survived, and I said I just met her that it's a miracle for you that you are alive today. And then she said, Dr. Sharma, you'll have to do this miracle again. I want a baby boy. I said, and another important thing for the postgraduate, please, is a contraception. No, whenever they deliver, after that you have to think about it. So immediately, I mean, postpartum IUD insertion can be done for them, or ligation if need be. I remember in another hospital, I can't name the consultant. This patient had Eisenmenger syndrome. She delivered and she survived somehow. At that time, mortality was 75%. She stayed in hospital for 3 days. She wanted ligation. But the consultant didn't do ligation. She said she will die of heart disease, and if there is a ligation case, I may be called to ministry, because any ligation patient, if she dies, whatever is the reason, it's a big inquiry. And she refused to do the ligation on that patient. Ultimately, patient went home. She fell pregnant again. She came back in second pregnancy and died. So no complaint, nothing against that. But then God is great. There is a higher power. This lady had CA breast. I mean. So you have to do judiciously. If they want ligation, please do ligation on them. Scared of doing ligation just for this reason that I may be called in.
There'll be no end to the stories which Dr. JB gives us.
Sorry,
because
I can't name.
That's a true icing on the cake, and therefore we always want our CGRs to
and tell them.
So that's why we always want to end on a happier note, and we always want JB to conclude that. Your last one.
If you're trying to collect data, you can also collect data about your MTPs for heart disease. Complications and anesthesia complications also, both the type of anesthesia. So that would also give you a lot of data.
Will be completing the picture as far as the AIIMS registry of heart diseases in pregnancy goes. Yes. Sure. Thank you so much for this. So thank you very much. Thanks.